consulted with many of my colleagues, medical oncologists, radiation oncologists, surgeons, and it was actually turned out to be a very nice task, and that I enjoyed tremendously. And I'll talk about what sort of the consensus was about the most influential things. It's not really in the last 2 years, maybe more extended into the last 3 to 4 years, but nevertheless, what we think are the really important things, or examples for important things. In the surgical field, minimally invasive surgery in most diseases seems to be a trend that is posed to make a difference in some sites, not in all sites, but in some of the GI sites. And I'll give an example of what happened in esophageal cancer with minimally invasive surgery. The other big thing that our chair at Penn, Jeff Drabin, thought is the most important thing that happened is really the advances in perioperative care. And what this does, it allows patients to survive major surgery, and it extends our ability to perform complex operations, vascular resections for hepatobiliary cancer and pancreatic cancers. So with minimally invasive surgery, the concerns, obviously, you've heard a lot about that, is the ability to obtain adequate margins, the extent of lymphadenectomy, peritoneum, and the possibility that this would actually spread intra-abdominal cancer, extraction of these large specimens via a port and port recurrences, the cost of it, and then the most important thing is the inadequate training and the steep learning curve that's been described many times. The benefits are faster incision healing and faster start of chemoradiotherapy or chemotherapy alone, and it's less immune suppressive. So in theory, it could be better than just open surgery, and it improves quality of life. The rate of adoption of minimally invasive cancer in the United States is increasing, and it's increasing actually quite fast. And the short-term outcomes are superior. The long-term outcomes seem to be equivalent, and we're just now starting to get some idea about the long-term outcome. And the major barrier is still training and the steep learning curve. So this is a publication from The Lancet that compared minimally invasive esophagectomy versus open esophagectomy. It was a few years ago, I think 2-3 years ago. And I point your attention to the arrows. They showed in this randomized Dutch trial that they reduced pulmonary complications. Within the first 2 weeks, they reduced pulmonary infections in the hospital. They reduced hospital stay. They reduced pain. And they improved the EORTC C30 quality of life. They also showed equivalence of the total lymph node that were retrieved, equivalence in the RZO resection rate, equivalence in the T stage, and equivalence in the mortality rate. But again, improvement in operative time, an increase operative time with the minimally invasive surgery, but reduced blood loss, again, reduced pain after surgery, and less interestingly, vocal cord paralysis.